Welcome to the discussion of the question ID number 4097 of the Uworld question bank. The present symptoms in this case was fever, 38.3 Celsius, there is malaise, there is a productive cough of clear sputum. There is unilateral right basal crackles, like vocal crackles, and there is occasional wheezes. You think about infection, fever and malaise is common. The absent symptoms are oropharynx, cervical lymphadenopathy, or rhinorrhea. There is no rhinorrhea. In the history of this case, he's an asthmatic with seasonal allergic rhinitis, and his son had fever, cough, and rhinorrhea 1 week ago. There is a contact. As we said before, rhinorrhea is absent. That excludes influenza, so you don't ask for rapid influenza test. The oropharynx is normal. Cervical lymphadenopathy is normal. There is no cervical lymphadenopathy. This can exclude tonsillitis, strep infection. There is no tachycardia, it's just 92. There is no tachypnea, it's just 20. Tachycardia, if it's more than 100 beats. Tachypnea, if it's more than 20 beats. There is no hypoxia, it's 96%. Hypoxia, if it's below 90%. What does that mean? It's not an exacerbation of an asthma. As we said before in the history, he's an asthmatic. Anyways, any infection can exacerbate asthma. This is something just to note. There is an infection. This infection can exacerbate asthma. That's why you can hear occasional wheezes. There is an asthma exacerbation, mild exacerbation. It's not severe. The heart sounds are normal. So these crackles are not due to any heart problem, like congestive heart failure, perhaps. And if it's due to congestive heart failure, it would be bilateral, not vocal. But in this case, it's right basal. There's no GI complaint. It's not mentioned in the case whether he had any GI problem or not, but he didn't complain of GI abnormalities or problem. The cough is productive, it's not dry. Dry cough happens in atypical pneumonia or atypical infections of the lung. The fever is acute, it's not like indolent in cases of mycoplasma. So that's why we exclude mycoplasma. We don't ask for agglutinin test, called agglutinin test. The auscultation is abnormal in one side, not in both sides. That excludes bronchitis, which we treat symptomatically. That's why we excluded it. It's not bilateral. It's not bilateral rales or wheezes. How do we manage community-acquired pneumonia? First thing, we ask for chest X-ray to confirm its presence. It might be these crackles, these focal crackles, might indicate there is a pneumonia. But we have to do the chest X-ray to confirm the diagnosis. Maybe it's something else. Maybe it was wrong. Maybe the entire case is made up. That's why we should do chest X-ray, so you confirm the pneumonia. The doctor might be faulty. Maybe he heard crackles, or there were no crackles. Sputum culture and stain are requested only if it's hospital admission, if there is hospital admission, if the patient is admitted in the hospital. Otherwise, we don't ask for it because it's invasive, or it's not invasive. You ask for it, it's costly. It's gonna cost a lot for this thing. While you can just ask for chest X-ray, it's gonna be sufficient to diagnose. And if he's not hypoxic, he's not in severe hypoxemia, then why would I do that? There's something called curb 65. The patient is not that old, like the age must be 65, and there's no confusion. Uremia, we have to do the test other ways. Respiration, there is no tachypnea, and the blood pressure is not decreased. Okay, that's why it's gonna treat like any other cause, like non-hospital admission. We do not admit him to hospital because of this. We use antibiotics according to this curb 65, and these antibiotics typically involve multiple things. You just go check them. You can go and check which to give with which, and there are many schedules for that. It depends on the guidelines in the country you're in, and in the USA there is a schedule for that. And that concludes this question. Thank you. If you have any questions, do not hesitate to ask. Best wishes.